Greetings. Let us go to the emergency room to see this patient with acute pancreatitis. So, this 55-year-old woman came into the emergency room with severe upper abdominal pain that radiates to the back and is associated with profuse vomitings. The pain has been constant and unremitting for the last several hours. It came on suddenly and she is suffering quite a bit. You also notice when you review the labs, her amylase and lipase are both elevated. The serum amylase and lipase were more than 3 times the upper limit of normal. So, when you have a patient with classic pain of pancreatitis, upper abdominal pain, unremitting pain, radiation to the back, and elevated amylase and lipase at least more than 3 times the upper limit of normal, you can make a diagnosis of acute pancreatitis. Incidentally, this woman also had a CT scan, and you look at the CT scan shows pancreatic gland enlargement and inflammation, along with a little bit of fluid collection around the tail of the pancreas. So, to make a diagnosis of pancreatitis, we depend on 2 out of 3 findings: classic pain, elevated amylase and lipase more than 3 times the upper limit of normal, and imaging study supporting the diagnosis of pancreatic inflammation. Now, let us go and learn about the etiology and pathogenesis of acute pancreatitis. Here is a normal, healthy pancreas gland. Pancreas is an important gland for the digestion of proteins, fats, and also carbohydrates. Most of the protein digesting enzymes are packaged in an inactive form and they are activated once they get into the duodenum. Whenever there is an injury to the pancreas, either from gallstones obstructing the ample of water, that is gallstone pancreatitis, alcohol intake, heavy alcohol intake continuously, certain drugs, and certain procedures, especially ERCP, they can irritate the pancreas and cause premature activation of the pancreatic enzymes inside the pancreas, which starts the process of autodigestion of the pancreas, and that results in pancreatitis. In the initial phase of pancreatitis, it is interstitial pancreatitis. And when you look at the CT scan of a patient with interstitial pancreatitis, the gland still shows enhancement with contrast, and there is no dead or necrotic area. Interstitial pancreatitis patients have an excellent prognosis and they recover completely. As the process goes on, the inflammatory activity releases free fatty acids and cytokines, and they cause a lot more damage. They act on the microcirculation and make the circulation leaky with the loss of fluid or third space loss of fluid. So this results in 2 things. One, loss of fluid into the third space results in tissue edema, and loss of fluid results in hypovolemia. So tissue edema, hypovolemia, and ongoing inflammatory activity, all of them work together to create organ dysfunction. And what are the organs that can get into trouble in patients with acute pancreatitis as it becomes severe pancreatitis? The organs that could be involved include cardiovascular system, respiratory system, and renal systems. So it could result in shock, non-cardiogenic pulmonary edema, or acute kidney injury. Patients with acute pancreatitis that have organ dysfunction tend to do poorly if the organ dysfunction does not reverse back to normal within the first 48 hours. Ongoing organ dysfunction is a bad prognostic sign in patients with acute pancreatitis. It is an it is an indicator of the severity of pancreatitis. As the pancreatic inflammation goes on with perfusion problems to the pancreas, secondary to hypovolemia and tissue edema, the pancreatitis can transform from interstitial pancreatitis to necrotizing pancreatitis, in which portions of the pancreatic gland become dead or develop necrosis. Once a patient with pancreatitis develops necrotizing pancreatitis, which happens within the first 48 to 72 hours, those patients tend to do poorly. Pancreatic necrosis, as it goes on after the second week, patients are at risk of getting infected and develop infected pancreatic necrosis, which is a very bad prognostic sign. So, we have learned about the etiology of pancreas. Pancreas protects itself from autodigestion because the enzymes are packaged in an inactive form. But if they get activated inside the pancreas, it starts the process of pancreatitis. Initial stage is interstitial pancreatitis that can be identified on the CT scan. And as the process worsens, you develop organ dysfunction from a combination of hypovolemic shock, tissue edema, and free fatty acids and cytokines causing the damage. In addition to organ dysfunction, the pancreatic inflammation can evolve into pancreatic necrosis, may develop infection, and get into trouble. And this pathophysiology is important to manage the patient well. And the key management principle, in addition to controlling the pain, as these patients tend to be in severe pain, it is important to manage the fluid status of the patient. That is, aggressive fluid resuscitation is the first critical step in the management of pancreatitis so that you prevent the pancreatitis from going forward to necrotizing pancreatitis. I hope this is helpful. Thank you.